So good evening, everybody, and welcome to this HTD seminar. My name's Anna Checkley. I'm one of the infectious diseases consultants at the HTD, and thank you all for joining us on this lovely sunny evening. We've got a masterclass in malaria lined up for you this evening, delivered by two very familiar names, Peter Chiodini and Colin Sutherland. First up, we've got Peter Chiodini, who really doesn't need an introduction. Many of us know him from his NHS roles in running the HTD Parasitology lab, as well as 2 clinics per week, and also covering the inpatient ward. But Peter also runs the Malaria Reference Laboratory, which is responsible for the surveillance of imported malaria, for providing diagnostic reference lab facilities, and for providing malaria prevention advice to healthcare professionals. And in case you were worried that this portfolio might leave him twiddling his thumbs, he also works with the WHO on hydatid disease, neurocysticercosis, and also on malaria RDTs. Of course, more of this shortly. In fact, some of us strongly suggest that Dolly the sheep was not the first mammal to be successfully cloned. And in fact, Peter beat her to it a decade prior, cloning himself when he was appointed to HTD in February 1985. Now, I'm not allowed to mention the R word, but that's okay, as this particular clone won't be retiring and will in fact be expanding some of these roles, including the MRL work. What other clones might choose to do is none of our business. And I think it's very appropriate at this HTD Centenary series to hear from someone who has been a consultant here for 37% of the HTD's existence. So Peter, over to you.
Anna, thank you very much indeed for that nice introduction. For this presentation, you're going to all need a working knowledge of lateral flow devices. Now, with COVID, that's not as big an ask as it used to be, but bear in mind as we go through this, that whilst we have very nice and I would say well-made RDTs issued to us for COVID diagnosis, the same isn't always true of the malaria devices, as you will see. Now, briefly, the Malaria Reference Laboratory and the hospital, when it comes to malaria, are a syncytium. A syncytium, for those of you who are not biologists, is one cytoplasm with multiple nuclei. And the nuclei are the people like Colin, me, Anna, who also works with us in the Malaria Reference Lab. And we cross both sites, hospital and MRL, and it's all the better for that synergy. Now, we lead on the malaria prevention guidelines, as Anna has said. These run to more than 100 pages, and actually if you've got a malaria prevention query and you look into them, it will answer it for you. They're very comprehensive indeed. If it doesn't answer it for you, it means it's high level, and then we are the final arbiters for that. There's a malaria prophylaxis risk assessment that we ask people to fill in, email it to us, and we email it back. And the new development to which Anna was referring is we're going to bring that much closer to the hospital now, so that we already have Anna and myself who work at both sites, but we're going to have our advisors doing the same. So I think that will greatly strengthen it. Now, the preventive arm really is designed to put the rest of the lab out of business. And I always say that travel medicine should really put my diagnostic labs out of business, but it manifestly has not done so far. So there's still a great need for reference microscopy diagnosis, reference RDT adjudication, and molecular assays. We produce enhanced surveillance for malaria cases imported into the UK. We have what's known as the blue coloured form, 2 pages of data, which informs then prophylaxis and treatment, as you'll hear from Colin later, a treatment policy as well. And we issue an annual report. Now, this is what we're trying to present. On the left here, we have a Paracetamia, really a quite overwhelming level. And here, acknowledgement to Claire Rogers, we have the headphones sign, the 2 earpieces and the band over the head. Got an accolade form sitting there, multiple infection. That's a horrendous Paracetamia with P. falciparum. That's a gold card to get you into ITU. It may not be a gold card to get you out of it unless we get the artesianate into you quickly. Here's a thick film. All of those are malaria parasites. And here, this is where the schizonts go. They're gumming up the cerebral capillaries. And this obviously, since it's a brain smear, was a fatal case. And that's what we don't want, and that's what we're trying to deal with. Now, there was a game changer in malaria diagnosis in 2010 when WHO said that in all settings, clinical suspicion of malaria should be confirmed with a parasitological diagnosis, which means microscopy or dipstick in a global context. Now, what are the options? Blood film. All my staff will get down to 20 parasites per microliter, and if they've had coffee and chocolate cake, they'll get down to about 5. Rapid diagnostic test, important to keep these numbers in your head, is reliable at 200. So a good microscopist will always beat an RDT, other things being equal. Molecular methods, WHO target for field use is 2 per microliter. RNA assays will go much lower, of course, and the LAMP assay, which is adapted for high throughput field use, will be similar. Now, in 1966, England won the World Cup, but a much more important event that year was the publication of Gardner's monograph on the malaria parasites. And the Wellcome Trust paid for these watercolours. They're not photographs, they're watercolours of the parasites to be produced. And it's a beautiful book if you can get hold of it. And this shows the ominous appearances of P. falciparum with the Marrow's clefts beautifully shown, and the gametocytes as well. So morphology still has a strong part to play. Now, what about the RDTs? They're not as straightforward as the COVID ones. COVID, you mash these swab around in some buffer, then you put 4 drops of that into the dipstick, and that's it. Here, you've got blood and a buffer stage. So bound antibody on the strip to detect the antigen, which is in red, detecting antibody to make a sandwich. And then if you've got positive for malaria, there'll be a red line from colloidal gold at the point where the test line is. And then there's rabbit anti-mouse, usually monoclonal, to detect the capture antibody. So capture antibody means the test works. That means there's antigen present. Now, what are the target antigens? Well, the target antigens, histone-rich protein 2 is the biggest one in the market by far, but it's P. falciparum only, bear that in mind. Lactate dehydrogenase and aldolase are both glycolytic enzymes, but can also be used in RDTs. And then some are single antigen, some are combined. Now, some countries buy 100 million RDTs a year. So when the biotech industry hears of those numbers, they all want a piece of the market. So there were lots of products. As an aside, this is the only one, the Binax, licensed for use in the US. It's the only FDA approved one. I think they're missing out on that. So they would not be allowed to use any of these others. Now, RDTs can fail. Why can they fail? Well, poor technique. People, I've given this to travel medicine experts to do and watch them mess up the test and not be able to get a result. So it's not as easy as you might think. You need good training. Low parasitemia, remember 20 for a blood film, 200 for a dipstick in terms of parasitemia. The antigen isn't there, and we'll come to that, or there's too much of it. And then finally, it's a poor quality product. WHO was finding that brand X of RDT was doing well in one country and not in another, or different batches of brand X were giving different results. So they introduced product testing. This is where I came in. I came in off the scale here in 1999 when we were called to a WHO meeting called New Perspectives in Malaria Diagnosis. And over the following years, along with all these other groups here, HTD worked on development of the program. And then we started testing products. And as the results came out, the bad ones went to the wall. And with the good ones, it was mergers and acquisitions. The market worked and the good guys were expanding, or sometimes the good guys were bought up by even bigger guys to produce the RDT. So much improved standards, and we've got the graphs to prove that. Now, this is how it worked. All the red dots were in-field collection sites, usually of falciparum or vivax, a global specimen bank. That was held at the CDC. Chin Cheng's lab in Queensland characterized the RDTs in the antigens in molecular terms. CDC did some of that too, and we did the antigen level measurement in my lab, HRP and lactate dehydrogenase. So quite a comprehensive program there. And this is the kind of stuff we got. Now, this is a busy slide, but I'll just take a minute to explain that to you. On the left, we have parasite detections, panel detection score. Green is 200 parasites per microliter, mauve is 2000. To pass WHO testing, they've got to get more than 80% correct. So all these would have passed. So far, so good. But what about this one? This has got a false positivity rate of 75%. So if I rushed around and tested all of you right now with that dipstick, 3/4 of you will be declared to have vivax malaria. Similarly with the falciparum, lots more products, because falciparum is the one that we really want to detect, and 80% will take you right over here. Lots of products to choose from. This one, again, lots of false positives. But plenty to deploy, and they were deployed with great success. Syndromic treatment is guesswork, and it offends me, the thought that people's lives depend on guesswork in the field because they can't afford to have diagnostics. So there was a massive game changer when we got these RDTs deployed in the field. And then came the Gremlin. This is how we met what came to be known as the weird Peru samples. Sophie Jones worked in my lab, then did her PhD with Chris Drakely at the London School and is now at CDC. When she was working with me in the lab literally next to my office, she knocked on the door one day and said, "Peter, we've got all these falciparums from Peru and there's no HRP2 in them." So I said, "Well, you better check that they are falciparum then." So Chin Cheng confirmed that in Queensland that they were indeed falciparum. And so they weren't making antigen, and Sophie put them back in the box. And I noted on the lid she'd written weird Peru samples, and I don't think I could have come up with a better name in many a go. And why? Because they were found to lack HRP2 and HRP3 genes and weren't making any. And again, this was Chin Cheng showed that, and also John Barnwell got involved. So the first publication of this was in 2010, and there's been a lot more since. So that's a big gremlin that we were kind of, well, David Bell, to be fair, from WHO predicted that it might happen, that dipsticks would evolve the malaria would evolve not to be detectable by HRP2 dipsticks. That's not the case in Peru. We think they arose de novo. So here's Peru, nothing wrong with Peru. It's not weird, but the falciparum were. Look also carefully at Sudan, Eritrea, and watch a late breaker of Zambia. The China data is pre-elimination. They don't now have malaria there. India, hovering. Nigeria, where we get cases, sort of hovering. So you don't sleep easily when you see a map like that. So it's got serious implications, obviously, for malaria control and elimination. WHO says don't use HRP2 based RDTs as a diagnostic tool when the prevalence of deletion is greater than 5%. Okay, now to be fair, in UK, if we had no dipsticks overnight, it would make no real difference. We'd still be as safe as we were before we had the dipsticks. The impact, the horrible impact, is going to be in endemic areas, and it doesn't bear thinking about if it really gets a hold. PLDH based RDTs, the leading one, didn't pass product testing. So we badly need better LDH-based RDTs. Quality microscopies are difficult to get and retain, and they're not well spread out in the areas where it matters. And molecular methods are great, but who can afford those in a poor country as a daily test? So the implication of this could be very bad if we're not very careful. And there's a very nice paper in Nature Microbiology. Leading author is Jane Cunningham from the WHO, pointing out that P. falciparum is effectively doing what David Bell said it would. It's evolving to escape, because if it's not caught by the HRP2 RDTs, then it can thrive while the other strains are killed off. As a result, Eritrea and Djibouti have already switched to alternatives, and the surveillance to inform that is underway in Somalia and in the Sudan. So what does that mean for us? Some cases. We've investigated 5, and the late breaker is Debbie Nolder from the MRL. Called me this morning when I was joining an MRL meeting to say we've now had a 6th one that we're investigating. But these are 5 I'm going to tell you about that we investigated with her and with Colin, who's speaking later. 72-year-old Sudanese lady comes to A&E. She's back from visiting her family, common story, a lot of visiting friends and relations. One day of malaria-like symptoms, blood film done promptly, good, malaria parasites present. Care start, which is HRP2 on the falciparum line, negative but positive on the pan-genus line. So they said, look, with this must be Vivax, referring to the MRL for confirmation. This is what we got. Care start and Binax both gave negative lines for HRP2, Optimal, which is LDH, positive for falciparum, and the pan line for all those three was positive. And the genotyping, negative for HRP2 and HRP3 genes. Thank you, Debbie, for doing that. Case 2, 17-year-old British male of Somali heritage comes to A&E. Now, this could have been a real disaster. 10-day history of symptoms suggestive of malaria. He'd had attention in Uganda, where the hospital test had been negative for malaria. We don't know whether he had an RDT or not. He got back the previous day to the UK, and his Binax was positive for aldolase, pan-genus, and though the admitting hospital thought he'd got Vivax. However, he got greater than 20% Paracetamia with P. falciparum, life-threatening infection, took him to ITU. So that miss could have been the end of him. So this is not without consequences. So what did we get on him? Well, the Care start falciparum line was weakly positive, but when we diluted it 1 in 10, it was clearly positive. The Binax line, similarly, negative to weak positive, comes up positive when you dilute it, and the Optimal was always positive, and then the pan lines are positive. So genotyping, the genes were there. It wasn't an HRP2/3 deletion. What we had was a Prozone-like effect. Now, if there are any pedants in the call, apart from me, because pedantry is good in science, Prozone strictly refers to absence of an antigen-antibody precipitation when you've got antibody excess. But in this case, with antigen excess, strictly you should call it a post-zone phenomenon, but nobody does, so it's got known as a Prozone-like effect, and that's what explained it here. So these are the 5 we've had. 3 gene deletions, Sudan, Ethiopia, which you've already mentioned, another Sudan. The Uganda was a Prozone-like effect, and here's another reason they can fail. Paracetamia less than 200 parasites per microliter. They saw the parasites. When we got it, we saw falciparum, but the dipstick was negative because there wasn't enough antigen, because the Paracetamia was too low. So where do we go from here? Well, hot off the press 2 weeks ago, published online, Claire Rogers, legendary microscopist from the MRL. Hello, Claire. I know you're planning to join us. Barbara Bain, Professor of Haematology Morphology at St Mary's, 3 general haematologists and myself rewrote these guidelines very recently. And this is what we say about dipsticks. Malaria diagnosis in general, first of all, the grade of evidence couldn't be higher. You need good quality thickened in blood films. They're 100 years or more old, this method, but it's still your best buy if you've got a decent microscopist. Do parasitemias for falciparum or Knowles eye. And this is the killer phrase. RDTs cannot replace microscopy, but are a supplementary test when you've got diagnosis performed by relatively inexperienced staff, but don't use them instead of a film at any time. And we're very hard-nosed about that. Now, this is interesting. You should be alert to the possibility of malaria even when the blood film hasn't been requested for parasites. So see low platelets. You're a haematology reg. The MLSO says, oh, you've got low platelets here. They usually do a film to correct that it wasn't clumping of platelets. Look for malaria parasites, and some autoanalyzers will flag it as well. Consider nucleic acid detection methods. Isn't time to discuss those, but they are coming in. And if there's a discrepancy, refer to the reference lab. Take part in the EQA scheme. We run microscopy, RDT and molecular EQA schemes, and we run the WHO molecular EQA scheme for malaria as well. And think about babesiosis. We've had 2 bad ones in the last couple of years here. They look like malaria and they'll never show on an RDT. So we say we do not recommend them in place of microscopy, because sometimes you get false positive with autoantibodies, rheumatoid factor, especially in the 1st generation test. They will never beat my microscopists. And also, if they were treated 2 weeks ago and they've got no parasites now, an HRP2 dipstick will still be positive if they had falciparum. Can take up to a month to go away. And it doesn't tell you the species except falciparum or Vivax. And it never gives you a Paracetamia. Would never have said 20% Paracetamia. Also, people can misread them. And this is not to be underestimated. People misinterpret the line patterns and then don't agree with the blood films. They can't pick up P. Knowles-I. You can't monitor a fall in parasitemia, and they can't tell you there are 2 parasites there. And then finally, you've got the post-zone or the prozone, whichever you like, effect. So 2 more slides. We're in a luxurious position here. Whatever you say about the health service, we can do first-line malaria diagnosis quickly and safely, and no one should die in the UK because they can't get their malaria confirmed in a lab promptly. In the malaria control and elimination programs, that's a credible threat, and the potential for resurgence, if that bites, and we have to go back onto alternative methods, is something that does concern. So we do need these better LDH-based RDTs, which will come, I'm sure. Over-reliance in non-endemic areas. In other words, if we rely on too much in the UK, the lab manager in haematology said, no, I'm not putting a BMS on overnight. You just do a dipstick and we sort it out next day. We don't like that. Continue quality assured blood film microscopy. And as I run the EQA scheme, I know that our haematologists are high quality and can do it. And the wider deployment of molecular platforms will come in. 2 slides of acknowledgement. Thanks to Sophie Jones, who's now an epidemiology intelligence service officer with the CDC, Roxanne, who's still with us after 12 years, and Spencer Polly, who did loads of work on LAMP-assay. At the London School, Debbie and Claire, whom I've already mentioned as legends, and the 3rd legend is Colin, who comes online in a moment, and the rest of the HD and MRL laboratory staff and clinicians, without whom none of this will be remotely possible. So thank you very much.
Peter, thank you for a wonderful, I'm just checking that I'm coming through. Thank you, Peter, for a wonderful, beautiful story, really, of RDTs and how they work and how they don't work. Really beautifully, clearly explained. So thank you for that. I think we will move directly on to Colin and save questions for the end, and we'll have a joint Q&A session at the end, if that's okay. But in the meantime, please do put any questions into the chat and we will come to them shortly. So moving on to Colin. Colin Sutherland is another malarious legend, and he's dialing in from the British Parasitology meeting at Castle Howard. Sadly, he was unable to procure a suit of armour to present in, but he did try. He's also interested in malaria and its evolution to escape, and I'm sure he'll talk about these ideas now. He's also an expert in malaria diagnostics, and with PLC and Spencer Polly, he's spearheaded the development of novel malaria diagnostics at HTD and in the MRL. But today we're going to hear from him about the subject that's probably closest to his heart. Colin has worked on the important issue of drug-resistant malaria parasites for over a decade, carrying out phenotypic and genotypic studies on drug resistance across Africa and also on imported isolates from the UK. Early on, he showed resistance mutations in isolates from West Kenya that differed importantly from those found in South Asia. And he's run and supported research and training programs across the continent, including a selection of widely dispersed PhD students, some of whom are now running successful programs of their own. So, Colin, when the drugs don't work.
Thank you, Anna. Are you hearing me okay?
Yes, we
Excellent. Are. And my slides are up, I trust? Good. So thank you to Anna and Michaela and the other and Charlotte who have helped facilitate my remote presentation from Castle Howard. And as Anna mentioned, I'd hoped they'd have a suit of armour behind me, but unfortunately the best I could rustle up was a decorative fireplace. So I hope you're enjoying that. And our dinner is at 7 o'clock, so the timing was perfect for me to join you live for this meeting rather than send a recording. So if I could indulge in a quick run through how I got to be doing what I'm now doing. I think it's quite interesting because it's quite different to the clinical pathways that many of you have travelled to get into tropical medicine. So I received my BSc and PhD from the University of Sydney, My BSc was in genetics, biochemistry, and zoology, and that was completed in 1983. I then worked for a couple of years, travelled for a couple of years, including a stint in the UK, but then eventually picked up a postdoc after my PhD back in Sydney. I picked up a postdoc in Darwin, and Darwin was where I started to learn my malaria stuff. And Darwin was an interesting place to live and work because you got to do quite a lot of this. And I got to work in a building shaped like a patient. And this building was designed with the help of Indigenous people from the area who wanted to represent health in the shape of the building. And it's still there and a very interesting place to visit. After my postdoc, during which I was also doing a part-time MPH on Indigenous health and tropical medicine, my partner Catherine and I went off for a year in China where we taught English, and she was studying Mandarin in her spare time, and I wrote my MPH thesis. When I came back to Darwin, just by sheer luck, I was only there for a few days to present my thesis. Brian Greenwood was in town. And I said to him, are there any jobs going in the London school? He said, yes, there are. Write to Jeff Target. So I wrote to Jeff Target and I got a job in the London school. And my job interview consisted of a BLT sandwich at the British Society for Parasitology meeting in Liverpool in 1997. And here I am at the BSP meeting, spring meeting in 2022 in York. So that's all a lot of fun. So I began working there on a lab project, but Jeff, being Jeff, took me out to the Gambia, and we secured some Wellcome Trust funding for me to run some clinical studies there, which were absolutely formative in terms of my understanding of the intersection between malaria science and clinical and field studies. And of course, actually being in Africa sort of also gave me the skills needed with Peter's help when I joined the MRL to receive my HCPC registration as a clinical scientist. And so Peter helped me prepare a portfolio which allowed me to make that transition to a sort of a quasi-clinician of a sort of a sciencey bent. So the rest of my talk, I just want to focus on some things we've done, but some fun we've had in the MRL and at the HTD over the last 15-18 years that I've been involved. And in particular, things that we did that have changed the world with respect to malaria drug studies and particularly resistance studies. So the first of these I'm going to talk about in detail is the qPCR clearance studies by Khalid Bashir and a whole host of HTD and MRL people. And also some other things I could have talked about as well is our early work in genomics. We were actually the first laboratory to provide fresh patient samples for full genome sequencing at the Sanger for Plasmodium falciparum. Not many people realise that. We've also done some very interesting studies on African isolate drug susceptibility. I won't talk about those very much. We're doing more and more work with P. Knowlesi, as Robert Moon at the London School has got a very good in vitro manipulation, in vitro cultivation system set up there. We've also looked at genomics with Susie Campino and Tani Clark at the London School. And one of the reasons that Peter's been successful and our budgets have been paid year on year out by PHE and now HSA is they realise the value of the way we can leverage not only the clinical expertise at HTD to support the work of the MRL, but also the research capacity in the London School itself So it's sort of balancing in this interesting world between basic laboratory science in malaria biology and the clinical practice of colleagues at the HTD. But of course, all these studies are all very well, and biologists can sometimes get carried away with art for art's sake. I want to keep us mindful of the benefits of some of this work to UK malaria patients, and of course providing advice for their physicians. So here's the original Bashir paper in the Malaria Journal in 2010, and you'll see a wonderful collection of ne'er-do-wells and larger-than-life characters here. In particular, it was great fun working with Stephen Wright at the time, and I don't know if Stephen's on the call, but greetings, Stephen, if you are. I'd also emphasise the importance of Chi as your fuel in this particular study, as she had a hair-raising story of one of her patients who had a very severe high parasitemia infection with P. falciparum of the kind that Peter has just described to us. And she just managed to grab the courier that delivered the blood sample and send him straight back on his motorbike to the home county's hospital he'd come from with artesunate and say, tell them to give him this now. Probably saved the guy's life, and he was in ITU for quite some time. But so he's one of the patients in this study that we did. And we basically looked at parasite clearance by the standard daily microscopy, which you see in the top panel here, and then in the bottom panel, the qPCR methodology that Khalid and I developed, which shows that, in fact, you get more time points that are positive because you've got a more sensitive test. And so you actually get a more accurate depiction of the clearance dynamics of the parasitemia. Now, that's all very well when you're getting nice fat 2 ml EDTA blood samples as the starting material for your DNA preparations. But in fact, we developed the test with an additional application in mind, and that was to be able to quantify malaria, Plasmodium falciparum in particular, but other species as well, quantify parasite densities in peripheral blood samples collected on finger prick filter paper blood spots in the field. And indeed, we've had success with that. And the most recent example of that is a very large study funded by the EDCTP with a consortium led by my colleague in Mali, Abdoulaye Jimde, and his collaborating partners in Mali and Burkina Faso, as well as our lab and a couple of others in Europe. But here we were able to use this approach on a very large number of patients treated with different ACTs. And let's move on to the next one. Yeah, and this is sort of an overview of that very complex main study in which over almost 5,000 patients were recruited across 5 sites and randomized to one of 3 or 4 ACTs, depending on which country they were in and what the front line was there. And of course, they were followed up for 2 years with a retreatment trial, so there's actually a total of 8,640 repeat malaria episodes. And we analysed with our clearance dynamics for about 500 of those patients. So that methodology is now used more in the field as well as in research laboratories. The second paper I want to speak about in a bit of detail was work that involved a whole bunch of HCD SPRs in the mid to late noughties. So we've got Faisal, Meredith, Thomas and others, Tom's there and Phil, as well as Spencer and Peter, of course, in the parasitology. But Helen Pfeiffer was the person who wandered into my office at the London School. This was part of her master's work, as I recall, in 2008, and could have been 2009, and said to me, I've got some strange sequencing data, can you have a look at it? And she'd found a brand new mutation in the PFDHPS gene, which is the target of sulfur drugs in the malaria parasite. Particular importance, of course, is sulfadoxin, which is half of the SP combination, but it may also be a key modulator of how parasites are affected by sulfathamoxazole, which of course they are exposed to in patients treated with Septrin. And of course, in Africa, Septrin is very widely used just as a general broad spectrum antibiotic, not least in people living with HIV who could be on antiretrovirals, but often will be taking quite a lot of Septrin. So there's a lot of Septrin around as well. So there are other sources of sulfur drug pressure on the malaria parasites. So this was a new haplotype. This is the codon 431 here, 436, 437, 540, and previous to this work, the most interesting and potentially dangerous haplotype were the ones that had this E at position 540. Those of you who've worked in East Africa would have seen the impact of this genotype in East Africa and some other variations on that. But here in Nigerian patients in HTD, these are the two haplotypes we saw with this new V and never with the E. And we went on to show that these were also very common in, well, not very common, but could be found amongst Nigerian isolates that had come into the MRL, and we published that work. So that was a discovery in London in our patients, and then we took that knowledge into a very large study of chemo prevention with SP and AQ in across the Sahel. And these countries across the Sahel that have a very long dry season and a very short, well-defined wet season, such as the Gambia here. Senegal uses this, but was not part of this study, but they do use this intervention. This is Guinea. Here we have Mali, Burkina Faso, Niger, northwestern Nigeria, and Chad. So quite an interesting transect east to west across this Sahelian belt, where there's a very well-defined wet season where all the malaria occurs. And if you treat children under 5, just for three monthly doses of SP plus amidiquine, it has a very good protective efficacy preventing malaria in that age group. So for this study, which was coordinated by Paul Milligan, they collected blood samples, 4,000 blood samples per country in each of 2 years. And Khalid ran an automated pipeline at the London School. It was a lot of effort to investigate that. And here's an example of the kind of data we got. These are the parasite prevalences in 2016. In the 2 age groups, we looked at the target age group for the intervention and also older people to see if there was any evidence that rolling out the intervention was leading to an overall change in the population mutation prevalences. And lo and behold, in this huge study, you don't need to absorb this table. I'm just trying to, blind you with science here. I can tell you there were, out of almost 60,000 blood samples that we tested, we found 7,300 that were qPCR positive. Most of these may well have been microscopy negative because all were asymptomatic. So none of these people had fevers or recent history of fever. And lo and behold, here is Helen Pfeiffer's haplotype. And we found it in 4 different countries. Mali, Niger, Nigeria, and Chad, and we now also know that it's really quite common in Cameroon. So you can see here, it's these 2 colours here, pink and orange. It's a relatively minor player, but the fact that it's spread across at least 4 of the 7 countries, and clearly has an easterly bias in its distribution was noted, and we are continuing to pursue that in studies of IPTI, which is now led by Rolly Gosling, who's back to the London School to run a large Unitaid funded program on that. So there's two examples that I'm very pleased to share with you, where work done in HTD and the MRL with UCLH ID physicians working together with us boffins in the lab have generated findings that have had a real difference in the field. And of course, that's really one of the things that we're all about. But I said at the beginning, what about the benefits for UK patients and their physicians? So of course, we don't use SP in the UK, we use ACTs. And we do know that in Southeast Asia, parasite resistance to both artemisinin and their partner drugs are posing a bit of a threat to effective malaria treatment. But happily, that's happening in a context where malaria is rapidly disappearing from that whole region. And I think I remember Chris Whitty's talk to us early in this series pointed that out very clearly, and that that in many parts of the world that kind of threat is diminishing. However, it's not diminishing in sub-Saharan Africa. So we've also documented cases of treatment failure with the ACT most commonly used in the UK, Rheumatoid, artemether-lumefantrine, in the UK. And in fact, my friend and colleague in Karolinska Institute in Stockholm, Anna Farnett and her team have also found a similar thing in imported cases in Sweden. So we do have occasional treatment failures with artemether-lumefantrine, and we're studying them very carefully. And in fact, you may be surprised to know that we've had 24 artemether-lumefantrine recrudescences that we documented between the end of 2015 and the end of 2019. Now, don't be alarmed, because that's 24 during a period of time where we probably had between 6,000 and 8,000 falciparum cases notified to the MRL, the vast majority of which were successfully and perfectly adequately treated with Rheumatoid. But of course, it's the unusual ones that are interesting. Now, I've plotted these 24 cases simply against a y-axis that shows you how many days after treatment of the first episode, which is day 0 here, how many days to recrudescence. And you can see there's a lot of variation. A couple of them were very short, one of which was a Cambodian isolate that had a K13 mutation. None of these African isolates had any K13 mutations. And the main thing I would say about this is there's no geographic pattern. This seems to happen right across the continent, so it probably isn't a focus of selection. And it has a variety of delays to recrudescence. And finally, there's I don't really see in this a pattern of an increasing threat at this stage. But that could happen very quickly, and indeed, we've recently heard from Didier Menard, Pascal Ringwald and colleagues in Rwanda that indeed there is a small focus that might well be growing and spreading into Uganda of potentially artemisinin-resistant parasites. The evidence so far is that these are not a massive public health threat, but may well be in the future. So just to wind up, this, of course, is highly relevant to us in the UK and to treatment of our patients and to advising our clinicians. Is there a real problem in Africa with artemisinin resistance? I think at the moment we would have to say no, but I think there's plenty of reasons to think that at least with artemether-lumefantrine, the efficacy when it was first deployed, when there were a lot of chloroquine-resistant parasites there that were easily killed by AL, that is tailing off a bit. But as I said, it doesn't yet appear to be a public health emergency, but clearly needs routine in vivo surveillance of ACT efficacy more widely, urgent validation of suitable markers in the African setting, which we don't really have, And of course, are there ways that we can use our current drugs in alternative treatment strategies? And something that I've been advocating for years and have discussed with Peter often is the idea of sequential ACTs, which I think will give a much better outcome, particularly with these potentially recrudescent parasites. Artemisinin is so rapidly eliminated from the body. I think at least 6 days are needed, and many people share that view. So finally, what we need, of course, are new drugs. And this is the MMV portfolio, which many of you will have seen before, but I would recommend browsing their website. This is not the most up-to-date version. You may recall I mentioned the large consortium chaired by Abdullah Jimdi in Mali, that's called WANACAM, the West African Network for Anti-Malarial Drugs. We've received a new tranche of funding for that consortium, and I was in Gabon last week to discuss progress in our phase 2 trial so far with this new combination. This is an artemisinin-free combination with the very promising anti-malarial compound KAF156, which Novartis are developing, and of course, being Novartis, they put it with lumefantrin because that's one of their babies. And we're looking at that now in phase 2, and we'll soon be moving into 2B, I think, or it could, 2B, larger phase 2B studies in a broader age group. So new drugs are coming along, and that's really useful. I see that I've used up my time, so I won't go into any more detail. I was going to say a few things about Plasmodium knowlesi. I'd be very happy to talk to anyone at any time about Plasmodium knowlesi. Drop me an email and I can tell you about some of the interesting things we've been doing with this species. And that's it from me. And just to thank all my wonderful colleagues that currently or recently have been with us in the PhD Malaria Reference Lab. Paul Lansdell did some early work on the drug resistance markers. And my current group at the LSHTM, who are always keen to interact with colleagues in the MRL and of course at the HTD. Thank you very much. Over to you, Anna.
Colin, thank you for a fantastic overview and again, a wonderful story told. We have almost 15 minutes left, and I think we will try to rattle through as many questions as possible. There's a lot of questions in the chat. Thank you very much. Please post now if you have anything else you'd like to ask. And I think for efficiency, we will have a stack of questions for PLC, and we'll then have a stack of questions for Colin, just to make switching between speakers easier. So PLC, let's start off with a question from Catherine Edgkevich, who sees a lot of falciparum malaria in North Manchester General Hospital. Not all hospitals have decent microscopists for malaria. The current guidelines, I think, suggest that RDT is adequate in an emergency. Are national guidelines changing? And how can we convince labs unused to looking at malaria films to reach out for help real time, not wait for an MRL result, which might take time if the hospital is up north? Peter.
Recently, with a paper with the Manchester A&E departments about.
Peter, you're on mute.
Okay, thank you. Right. Okay, can you hear me now?
Yes, we can.
Perfect. Okay. Hi, Catherine. You're fortunate that in Manchester you have very high quality malaria diagnostics. We've collaborated with the haematologist at Manchester Royal, and I can send you the paper on that. But basically, it all depends on convincing your local laboratory manager what they're going to deploy out at night. And the first port of call is those guidelines which have just come out, which are British Society for Haematology guidelines that you ought to put in front of them. And we're really saying that you need dipstick and microscopy. If they don't do dipstick, if they don't do microscopy and rely on dipstick alone, it's essentially on them. My view, I take a strong view on this, is that microscopy is cheap. Let's take the example. Somebody pitches up to A&E with a transient ischemic attack. They'd be plugged into a CT scanner almost before they've been clamped. Put the cost of that against the cost of malaria film, and it's at least 20-fold the cost of that CT. So it's all a matter of educating the people. and pathology budgets get squeezed, and it's often an excuse to cut the out of hours stuff because they're short of money. So I would take those set of guidelines to the people in your hospital, especially if you're an ID unit. You should have it. The other thing you could have, and there would be enough demand for it there, is you could deploy LAMP or the Alethea molecular method, which will go down to 2 parasites per microliter. The LAMP is plug and play, it's cassette based, and you could do that out of hours if you really can't get them to do a blood film. So contact me offline, I'll send you the PDF of that British Society of Haematology guideline, but we shouldn't let them off doing blood films just because it'll save them a bit of money, because down the line I don't think that's acceptable.
Brilliant, that's lovely. Thank you, Peter. So I think we'll move on to the question, how long is long enough for treating a patient with a high parasitemia? Do you think we should be more proactive about extending treatment? Isn't treatment failure due mainly to undertreatment? And I think probably that I'll put that question to Peter as a clinical question. Thank you.
Okay, well, it alludes to what Colin was saying. Some people say you need 3 optimally, and this is David Sullivan from Johns Hopkins, that optimally you need to cover 3 cycles of the malaria parasites. That's 3 times 48 hours, which would be longer than the current treatment regimen. So what we would do with hyperparasitemia, you're going to be on artesunate. You can go with artesunate for a week if you need to. So you drive down the parasitemia with that, and then you're consolidating with a second agent. And in the hyperparasitemia, you're always going to deploy parenteral artesunate first. You can then take them off that and put them on an ACT. You've also got the option of following up with clindamycin or doxycycline, or even another very good alternative is to use Malarone, which is a different class of action. But daily parasitemia until you're below a certain threshold, as you know, and then you'll kick in with your oral agent.
Thank you. Thank you, Peter. And then Daniel Pan would like to just push you slightly and say, do you think malaria RDTs should be used at all in non-endemic areas such as the UK, since review of blood film should always be available in the UK within 24 hours?
Okay, I mean, as I said earlier, we could get away without them completely. And if you wanted to be nihilistic, you could say do a blood film and have rapid access to PCR. But the RDTs are useful, as we say in those guidelines, in the context of if you've got somebody on at night who doesn't see a lot of malaria. Like when I first joined HTD, we saw 1 falciparum malaria every day, 365 literally in a year. Now, with lots of other ID units in London, we do about 100 each, several of us. If you're in the Cotswolds, you may not see malaria from one end of the year to the other. And if you're in the Channel Islands, where they do actually use Alethea, the molecular method, they may not see one at all in a whole calendar year. So if you're on at night and you see a malaria parasite, you do a dipstick and you get then a falciparum line, that's going to help you, because the later trophozoites of falciparum can be confused with vivax, with the Maurer's clefts and so on. So I think it's a useful adjunct. I really do. I don't think we should ditch them. But like any diagnostic test, you need to know the limits of what it can do for you. And some people use them as a black box, you know, it's malaria or it's not malaria. It's not quite like that. So blood film is still your best friend, backed up by an RDT. And in some areas close to, say, the Liverpool School of Tropical Medicine, the local hospitals there will do that. And then they're on the doorstep of the Liverpool School in the morning for confirmation of their microscopy. We are not wanting the MRL used as an immediate diagnosis. That's not what we're there for. So you need to get the diagnostics worked up properly locally. Out of hours, HTD does do a 24/7 on-call, so you can send one in 3 o'clock tomorrow morning to my lab at the hospital and we'll diagnose it for you. If you're really stuck, we offer that service. So I think dipsticks do have a part to play. You just got to deploy them appropriately with the blood film.
Wonderful, thank you. And moving quickly on, we'll see if we can cram as many questions as possible in for Colin. So Colin, Catherine Ajkevich again would like to know, she says, I recall exchange transfusion when we only had quinine for severe falciparum. With artesunate, this has become obsolete, thank goodness. But there is always the concern that misuse of artemisinin may lead to resistance. Are there any drugs in development, or does Colin or PLC have a crystal ball to think how we may be or where we may be in 10 years' time? And another person on a similar line has asked you the question, put your money where your mouth is, Colin, will we be using Rheumate in 5 years?
Right, there we go. Unmuted. Great questions, and I love the opportunity to discuss this which is very close to my heart. This topic. I don't think that this resistance mechanism that we're seeing for artemisinin is as much a threat as people think, for exactly the reason that Peter gave. If you extend treatment with artemisinin to 5 or 6 days, then you really can eliminate even these so-called resistant mutant parasites, and that's because the benefit of the mutation, it only operates during the first few hours of the ring stage. So if you go through enough life cycles, eventually they're going to be encountering artemisinin at stages in the life cycle that are much more susceptible. That's the first thing. The second thing is I think there's a great opportunity to use sequential combination therapy. And some colleagues may not be aware that dihydroartemisinin piperacin, whose trade name I think is Uraticim, if I'm not mistaken, that's been approved by the EMA, and I think it can be used in the UK, but up to my knowledge, it's not really in many pharmacies. I would be very happy to see people where it's indicated, not where treatment is working well, but where it's indicated to have a follow-on second regimen of DP following AL, following Rheumatoid. That's partly because piperacin and lumefantrin have independent modes of action. And so the two partner drugs will have no cross resistance. And the that's a way of getting 6 days of artemisinin. But of course, Peter's suggestion is also very sound, where it appears clinically indicated starting a patient for 2 or 3 days on IV artesunate as a monotherapy, followed by my recommendation would be a normal oral ACT, either AL or dihydroartemisinin piperacin, Uraticim. So I look forward to hearing from some of you that you started using Uraticim. Please let me know if you do.
Fantastic, thank you, Colin. And just in the last couple of minutes we've got available, I can just squeeze in one last quick one, if that's okay. What surveillance is done to detect ACT resistance in imported malaria?
Well, it's nothing systematic, so we're relying on you. And I saw a question from somebody saying, do we look at parasites from outside of London? Of course we do. Send them in, EDTA blood, in the post. And the thing is, if you have a treatment failure at day 25 and you send it to us and you didn't send us the day 0 sample, we have a far weaker chance of identifying we can't compare with the original treatment isolate. So send all your isolates to us, to the MRL, and then when you get a treatment failure, you'll be glad you did, because you can then we can compare before and after. I hope that's been helpful, and I'm easy to find. Please send me emails with any further questions. I'm very happy to interact with clinical colleagues. Thank you.
Colin, that's wonderful, and I'm just sorry we didn't have time to go through any more of the questions. And please, Colin and Peter, if you want to quickly put other replies in the chat, then please do. So that just remains for me to thank both Colin and Peter for giving us an amazing masterclass in malaria this evening, and to just briefly highlight the next series in our centenary series of seminars. So next, coming up at the end of April, Emma Wall, ID, and Laura Benjamin, neurologist, have prepared a smorgasbord of neurological ID tidbits to interest you, with Temi Barucha and Rachel Brown starting off describing the National Hospital for Neurology and Neurosurgery and UCLH neuroencephalitis MDT, with some really fascinating cases and trends in terms of what's being discussed there. Then Professor Judy Brewer is going to talk about state-of-the-art CNS diagnostics. Professor Rolf Jaeger is going to talk about state-of-the-art CNS MRI imaging techniques. And then dispersed through all of this will be a whole range of fascinating cases. And just to point out, we generally have a seminar on the 4th Thursday of every month, but this will happen 1 week earlier, the seminar after next. So the seminar in May will be on the 19th of May. And I know some people have found it hard to access the schedule for all of the seminars. There on the slide is the web address that you need. If you click onto that, you can see everything that's available and you can book yourself on. You need to book on individually onto each session that you want to attend. You can't just sign up for the whole series. So thank you again to both of our speakers, and thank you to our audience for joining in and asking such stimulating questions, and we'll see you again next month.